Exemplifying once again the unique and exclusive coverage provided by Audio Digest and the speed with which it can be brought to our subscribers, you're sitting in Chicago this week for the just concluded 1970 Clinical Congress of the American College of Surgeons via Audio Digest Surgery, Volume 17, Number 21. And this, the final day of the Congress, finds us at the Conrad Hilton International Ballroom, joining hundreds of others who've turned out for the What's New in Surgery session, as several distinguished surgeons summarize the important surgical findings presented during the 5-day Congress. Presiding over the session is the University of Miami's W. Dean Warren, who's now ready to begin. Let's listen.
We have a lot of interesting speakers to hear. Dr. William Drucker is to begin the program. Dr. Drucker is professor and chairman of the Department of Surgery at the University of Toronto, and he will initiate the program by discussing what's new in the field of shock and metabolism. Dr. Drucker.
This year, the presentations in both shock and metabolism covered a wide range of interests, and I'll go through and pick out the ones that I felt were particularly interesting, at least to me. The work from Colorado by Grover on using Puronic F68 is interesting because it may be an agent that will promote an increased flow under circumstances in which peripheral flow has been decreased, namely shock from any cause. This is preliminary work, and I think we'll be seeing more from them, and hopefully others will take this up and see whether this agent can indeed be an adjunct to therapy in those situations in which flow has been curtailed for any reason. Price at Galveston has performed a long overdue study. The role of hypoosmolality on renal function was investigated by McCants on British medical students back in the 30s. Why this has never been extended to other organs is unknown to me, but finally Price has come forward now with Derek and colleagues at Galveston and has studied the effect of hypoosmolality on cardiovascular physiology. Unquestionably, a low sodium concentration decrease in osmolality will impair cardiovascular function. The details as to why this occurs require further study. Spiegelman, in a very interesting study and extension of work by many others, has shown that glucose and insulin as a treatment for hypovolemic shock has merit. There's work in England by Allison, by Fleer, and by others that would say that this has value also in cardiac shock, in septic shock, and in burn shock. Kaplan has presented an interesting paper on prostaglandins. These are biologically active free fatty acids, and their paper suggests that these substances may be released from carcinoid tumors and perhaps may even be present in normal states, could be responsible for diarrhea. So we have another agent in that long list of agents that may be responsible for diarrhea in patients with carcinoid syndrome, and perhaps it may be responsible for diarrhea under other circumstances. The work done by Charlie Baxter and Burns, and he just makes a point that the fluid loss in the early stages of burns may be more severe than we sometimes recognize, and that our therapy should be more urgently applied, that the old division of therapy perhaps is not as rapid as it should be, and that we should be giving more fluid, or at least give our fluid faster than we have in the past. Work from Jake Fine has finally come up with a means of quantitating endotoxin. As you know, for many years, Dr. Fine has postulated there is a toxin in the blood with shock, but his work has been discouraged a bit by the fact that it's not been possible to identify this toxin. Well, within the past year, he has now found that he can have a biological assay, and it seems to be rather critical, and it seems to be rather specific for endotoxin. The work that Reinhold presented to the forum utilizes this assay method in a continuing study of endotoxic shock. You have heard and will continue to hear much on hyperalimentation, and all I wish to mention here is the discussion by Dr. Jones on Monday morning, in which he points out certain dangers of hyperalimentation. This in no way means that hyperalimentation is not worthwhile. It's just to give us some idea that it's not completely benign, nor has anyone ever implied that it is benign. If the solution is run into rapidly, there's a danger of an osmotic diuresis. Work on diabetes many years ago has told us that it really takes a fairly significant degree of hyperglycemia before an osmotic diuresis occurs, but there's no question that the reason patients with diabetes get into trouble is because they develop, if you will, hypovolemic shock due to a diuresis of salt and water from the glucose in the urine. And this can occur just as well in the non-diabetic if we make them too hyperglycemic for too long a period of time. Hyperosmolality is a different problem. If patients are given a hyperalimentation, I don't really like that word, but if they're given a hyperalimentation, if there isn't enough water provided, can increase the number of solutes in the blood, and this will pull water out of the cells and can overexpand them to the extent where they can go into heart failure or lead to cellular desiccation. Hypophosphatemia may or may not be a serious problem. We do know that if one gives glucose and insulin, one drives the phosphorus down as the glucose is metabolized and becomes phosphorylated and goes to glycogen. There's always this question of hypersensitivity to any intravenous infusion. This is no longer present with glucose, of course. We rarely see that, but with the protein, and particularly with fat, there's the problem of hypersensitivity. There were 6 papers on the forum that dealt in general with mitochondrial changes. This is a field that I think we'll see more activity in now that the technology is available and that surgeons are becoming interested in these studies. There are a lot of questions whether these are valuable in the shock situation, because in the process of studying mitochondria, artifact is produced in just getting the mitochondria out for study. But this objection can be met in large measure if sequential studies are made, because then whatever artifactual problems there are in the technology of studying mitochondria are the same throughout, and we see relative changes. And if we stay with the relative changes rather than specific changes, I think we may get some valuable information. It's interesting that we're beginning to find out that despite no apparent morphological alteration, mitochondrial function may be abnormal. One of the other problems that happens is that abnormal mitochondrial function in vivo sometimes cannot be picked up when the mitochondria is taken out and studied in the isolated in vitro situation. There's interesting work, follow-up of earlier work of Janoff, of course, that lysosomes are released after prolonged shock. And this work utilizes a very nice histochemical technique developed by Rutenberg and can identify the lysosomes in various tissues of the body. I think we're going to see more and more on mitochondrial metabolism in studies of shock. As you know, the problems of the lung in shock became quite serious, and so much so that a conference was organized in Washington about 1.5 years ago to investigate them, and now the investigators are going in more detail to find out why are there pulmonary changes with prolonged shock. Siegel tried to determine whether there's more chance of getting pulmonary changes if saline or colloid was used, and he actually showed in his study anyway that if anything, colloid was worse than saline, as sort of in defense of the idea of giving saline, if you will. Collins did some very interesting studies on lung weights and used various resuscitative fluids and came to a conclusion that really the different types of fluids didn't make too much difference in whether or not there are pulmonary problems. But something to the attention, I think, that many of us had recognized, that lung changes frequently will not occur until the human has been resuscitated. There's something in the resuscitative process that leads to the pulmonary changes. Work done by others would suggest that it may be something in the transfused blood, or it may be something washed out of tissues that leads to pulmonary changes. Work from Watts-Webb's group suggests that there may be a venous constriction in the pulmonary circulation, and therefore fluid is lost into the interstitium because of this change in the physiology of the pulmonary veins. And this is not the answer to the problem, but it shows there's a fair amount of interest in this very serious problem. Larry Carey came forward with a long overdue study and in very clear terms helped to explain why there are some discrepancies in the shock literature. It depends so much on the model that one studies. Not only is there a species difference, but in any given species, a lot depends on whether the hemorrhage is produced slowly or rapidly. And he shows that there's a rise in blood glucose with an acute hemorrhage, where with a graded hemorrhage, even though eventually it may produce the same total volume loss, if it's a slower loss, there may be no rise in glucose. And he extended this study to show there may be no marked endocrine change, so that when we're talking about metabolic and endocrine changes in shock, it's important to recognize that shock is a dynamic sequence of interrelated events, and one must be aware of both the time and the severity of the shock at the time particular studies are made. A beautiful study from Jerry Austin's laboratory in Boston, where he had a great group of talent put together to show that transfused blood may actually be dangerous because of what it does to the oxygen dissociation curve. The massive transfusion of stored blood can be dangerous because of the properties in that stored blood. A lot of people are now becoming interested in the capillary circulation, the interstitial fluid, and the cell. And just very briefly, there's one group that says that resistance or refractoriness to therapy is due to changes in either the permeability or the dynamics of transcapillary exchange after prolonged shock. Coven suggests that there may actually be, if you will, clotting in the interstitium because of the physical-chemical properties of the ground substance. And there's a whole exciting new field developing. Cunningham and crew from Texas with Tom Shires Byers, Basil Pruitt and his crew in the Army, and of course Cecil Fleer in England have all directed attention to what's happening in the cell and whether or not it takes up sodium and solutes after a prolonged period of shock. And some of the studies have been in the red cells, other studies have been in tissue cells, and I think this is an area we're going to see much more active interest in, the idea being after a prolonged period of hypovolemia, something happens to disrupt, not necessarily mechanically disrupt, but to disrupt the physiology of salt and water exchange across the cellular membranes.
The second speaker, Dr. Jerry Austin, professor at Harvard and chairman of the Department of Surgery at the Massachusetts General Hospital.
I have chosen to discuss 6 broad areas in the field of cardiothoracic surgery. Coronary artery surgery. Operations for coronary artery disease have become perhaps the most exciting new area in cardiothoracic surgery. There have been rapid changes in this field in recent years, and surgical treatment is now a relatively well-accepted approach. The importance of these breakthroughs is self-evident when one considers that over 600,000 patients died of coronary artery disease in the United States in 1968. Soanes has re-emphasized the importance of careful and complete coronary angiography and left ventricular angiography in the evaluation of all coronary patients. Over 19,700 patients have been studied by Dr. Soanes' group with a mortality of less than 1 per 1,000. Both the Cleveland Clinic group and the Milwaukee group have expressed pessimism regarding revascularization of acute infarct patients. Their results have been poor under these circumstances. They do stress the urgency of proceeding with patients with severe chest pain and an impending infarction. Left ventricular complications of coronary artery disease are being handled with increasing frequency and success. Kaiser has presented an excellent series of such patients treated at the Columbia Presbyterian Hospital. Infarctectomy continues to be of interest, but survival is difficult. Kaiser has mentioned a recent series from the Massachusetts General Hospital in which infarctectomy and closure of ventricular septal defect in 4 patients was successful in every case. Resection of an akinetic area has modest success, whereas resection of a true chronic left ventricular aneurysm has had an excellent success rate. The results of mitral valve replacement for papillary muscle dysfunction and rupture are also excellent. Valve surgery. The experience of the last 10 years of valve replacement discloses a monumental record of intense activity that has had a general movement of progress. Prosthetics have been most commonly employed. Prosthetics mimicking the natural valve have not been very successful to date because there is no appropriate material that is sufficiently durable to withstand the stresses of repeated flexion. Thus, the caged poppet with a rigid ring has been most popular. The earliest employed and most commonly used is the ball valve. Various modifications of the ball valve design have occurred, including changes in flow configuration, the use of a metal ball, and the covering of exposed surfaces with material that will allow tissue ingrowth. The primary concerns regarding prosthetic valves include clot formation and embolization, pressure gradients, and ball variance. The Starr-Edwards valve 1200 aortic series and 6120 mitral series have had only rare instances of ball variance and satisfactory hemodynamics, but embolization rates of approximately 5% or more for 2 years of follow-up with anticoagulations are common. More recently, the Starr-Edwards totally covered metal ball model 2310 aortic valve and model 6310 mitral valve have been introduced. Emboli rates have been in the range of 2 to 3% in the mitral position and even lower in the aortic position. Anticoagulants may or may not be necessary. Many discontinue anticoagulants at 6 months. Magoon and Spencer have indicated that this type of valve is preferable at the present time. They indicate that the low-profile valve does not have ideal characteristics of wear and is associated with higher embolization rates. They rarely use these types of prosthetics. The newer hingeless valves have not been employed long enough to give assurance regarding the poor wear characteristics of early models. Magoon and Spencer have indicated that recent results with prosthetic valve replacement of either aortic or mitral type have demonstrated a hospital mortality of approximately 5% and a late survival rate at 4 years of 75 to 80%. Cardiac transplantation. Cardiac transplantation continues under intensive investigation. Lauer indicated that experience to date has shown no significant technical or physiological barriers to the use of cardiac transplantation in the salvage of patients with terminal heart disease. Tissue typing to the present has been of little value in predicting graft prognosis, with the exception of avoiding positive cross-match. Rappaport, however, suggested that newer, more sophisticated interpretations of tissue typing may be very useful in predicting transplantation success. 162 patients to date have undergone cardiac transplantation. There are 21 living and 16 living for more than 1 year. Although death from chronic rejection has continued in patients after the initial postoperative period at a fairly steady rate, currently 10 patients have lived for more than 21 months with no deaths in this group. We can only hope that these patients may have passed a critical period of graft acceptance. Long-term survival patients are in general very well rehabilitated. The possible future expanded use of this procedure, however, requires more precise control of the immune response and better methods of organ storage. Congenital heart disease. In the surgery of congenital heart disease, increasing emphasis is being placed on early total correction of complex cardiac defects, even in the first year of life. Dillard has presented exciting results of total correction in infants using deep hypothermia and circulatory arrest. Kirkland and Baumann have also shown similar results employing bypass techniques. Baumann and also Kirkland emphasized the early good results achieved in reconstruction of anomalies of conus development by employing aortic homographs as reported by Rostelli and Magoon, or prosthetic conduits with fasciolata valves. Mom has emphasized the need to continually weigh the risk of total correction of complex anomalies at an early age versus the combined risk of staged procedures. Circulatory assistance. Circulatory assistance remains an important and active area of research. A number of different approaches have been investigated, including counterpulsation, lower extremity external pressure counterpulsation, inaortic balloon counterpulsation, mechanical ventricular compression with a cup, left ventricular bypass, the auxiliary ventricle, total heart replacement, and cardiopulmonary bypass. Kennedy has reviewed these methods and has pointed out the increasing potential of external pressure technique, the intra-aortic balloon, and cardiopulmonary bypass. A number of groups have a number of survivors with the intra-aortic balloon treatment of cardiogenic shock. Patients have been pumped for up to 14 days. Cardiopulmonary bypass has been employed for short periods, up to 4 hours at Baylor, in 32 patients with 9 long-term survivors. It should be mentioned also that the Baylor group has 2 long-term survivors following left ventricular bypass after up to 9 days of treatment. Techniques of partial circulatory support appear particularly important for short-term maintenance of the circulation, during which time such patients may be studied to define surgically treatable disease. While clotting problems and blood-formed element destructions have limited permanent heart replacement, progress has been made in the area of compatible surfaces and also in the area of miniaturized atomic-powered engines. Although much work needs yet to be done, the future of mechanical heart replacement appears promising. Pulmonary disease. The pulmonary problems of the critically ill patient and the patient with marginal lung function continues to be of considerable interest. Laver has pointed out that oxygenation and not CO2 exchange is usually the major problem in such patients in the postoperative period. Pulmonary interstitial edema and mechanical interference with lung expansion causing atelectasis are the 2 principal factors preventing efficient oxygenation. Both result in disturbances of the ventilation-perfusion relationship. Pulmonary edema should be treated with appropriate fluid restriction and diuretics. This will usually result in a marked increase in arterial PO2. In any patient receiving a high inspired oxygen concentration on a respirator who has a low arterial PO2, in spite of all usual therapy, the end expiratory pressure should be raised. This maneuver will help to maintain the alveoli open at end expiration with improved oxygenation. Whereas such an increase in peak airway pressure may decrease cardiac output in the normal patient, this usually does not occur in the situation where an elevated end expiratory pressure is required. In such a patient with a low functional residual capacity and resultant increased pulmonary resistance, the increase in pressure increases lung volume and usually decreases pulmonary resistance. The cardiac output may be unchanged or frequently rises. The introduction of the elevation of end expiratory pressure in appropriate cases has significantly influenced the outcome in this critically ill group of patients. An important complication, however, is a pneumothorax.
The next speaker, Dr. Robert Ryan, is the chairman of plastic and reconstructive surgery at Tulane and will give us the survey of what's new in this area. Dr. Ryan.
I would like to call your attention to the use of the Doppler in deciding whether or not the congenital hemangiomas are going to regress or whether they're going to go ahead and progress. As you know, in the individual patient, this can be a very difficult problem to care for, and I believe that we now have a way of evaluating these through this method. This is by Hal Bingham and Lichty. One of the most spectacular advances this year was of Edgerton and Jabalai on the osteotomies and mid-face restoration. These are in the children who have the Cruzon or Alpert syndromes where there's been failure growth of the whole mid-face. What a spectacular achievement this is in terms of restoring these children towards normal. In regard to wound healing, there are several very interesting developments, and of course, Peacock, Trier, and Madden. Just to be sure that I don't get things wrong, I'm going to quote you the last sentence of their paper. These results suggest that the use of multiple agents may make it possible to induce controlled clinical laterism in human beings with less undesirable side effects. I think that for the first time we now see the possibility of real approaches in this area of controlling wound healing and the laying down of collagen in our wounds at a molecular level. Certainly this is a field that is very exciting, and we will be looking forward to hearing more about this in the near future. Hand surgery came in for a great deal of coverage at this meeting, and there are several interesting developments that are now present. Any of you who've done hand surgery, have repaired tendons, and I'm sure most of you have at some time or other, have probably had the sad experience on occasions, if you're like me, of finding a tendon that just doesn't work, and you go back and look in this space, and there in no man's land is just a solid mass of scar tissue. We now have two interesting concepts that are important because they allow us to preserve that space so we do not lose that space and can once again get the area working. First is the work of many men where they've sewn in as a primary thing the silicone rods, or as Dr. Bader of this city has shown, using certain slings and olive elastic to preserve the space. Then going back at a later time and doing your definitive tendon repair or graft. The other work, which was presented here and showing the good effects of the tendons, how they preserve their strength, using these xenografts. This is the work from the National Naval Medical Center, and they have shown that using not only the tendon, but the entire tendon sheath, the whole unit being transplanted, these can be freeze-dried so that they're readily available. They can be stored, and you can have them, put them in whenever you need them. These will work, and what happens is that you preserve the gliding mechanism of the tendon inside the sheath, and your whole graft reaction of scar tissue forms around the outside of the sheath, and yet the sheath itself still works and the tendon will glide. I think this is a most important thing because here now we can develop an excellent model for study to see what does happen in these tendons. The other thing that was so exciting for those of us who were in the hand session the other day was the subject of implantation of digits. Many of you have seen the beautiful work that Harry Bunke from Stanford, Jim Smith from New York, and others of the Plaster Group have been doing in the microcirculation and the use of instrumentation for hand work. Doctors Owen and Ledvay, two surgeons from Australia, were present at our meeting and presented our work. Using the basic instruments developed by Bunke and others and these techniques, they have gone on for the reimplantation of limbs. They reported on the successful reimplantation of 8 out of 11 digits. This is a great milestone in the reimplantation of fingers when they have been removed through sharp instruments such as a thumb that's been removed. And up until now, nobody else had had this success. They've varied the technique, and I think that now will be possible for many others to go ahead and using their techniques to do this same work. I would call your attention to the symposium that was held on surgery of the breast. Carl Chisholm from Seattle emphasized the point that cancer of the breast in the female is prevented, and more women will be salvaged if we would do more of the bilateral subcutaneous mastectomies. If you have patients with chronic cystic mastitis, severe mastodynia with each menstrual period, positive family history, either in the mother, older sisters, aunts who have had cancer of the breast, women who have had multiple biopsies of the breast, or a diagnosis of a premalignant or in situ lesion, these women should have bilateral subcutaneous mastectomies. This should be a general surgical procedure. I think that if more of it is done, we will salvage many more women. I think that the day when you can do a simple mastectomy and creating a psychological and physical cripple in these women by removing all of the breast is past. There is no need to remove the nipple and areola from these women. They appreciate very much the fact that if one does do a subcutaneous mastectomy in these premalignant conditions, and then go back either at the same time if your circulation is adequate, but if there's question about the circulation or viability of your flaps, or if the flaps are large and a pendulous breast, simply use your inframammary incision, let them heal down, and then at a later date the implants can be placed.
The proceedings pause momentarily, long enough for me to signal the end of Side A of your program, Doctor. On Side B, the remainder of this special report from the American College of Surgeons' 56th Annual Clinical Congress, heard by just flipping over your recorder's cassette or two reels. Continuing a special report from the What's New in Surgery session of the American College of Surgeons' 56th Annual Clinical Congress in Chicago, this is Side B, Audio Digest Surgery, Volume 17, Number 21. Now Dr. Robert F. Ryan discussing newer developments in the management of burns.
Now, in terms of our burns, one of the definitive papers on the program this year in the surgical forum was that of Iverson and Lobb from Stanford. They showed the treatment of choice in hydrofluoric acid burns is the local injection of 10% calcium gluconate. They compared the other methods of treatment, and the results were very striking. I think all of us are going to be seeing many more of these burns in the future than we have in the past, especially since this agent, they tell me, is now included in many of the household cleaning agents for rugs. So many of you will probably be seeing children who have these burns. In regard to thermal burns, we've come a long ways since that milestone, the work published by the Brooke Army Group in 1955, SGNO, May issue, on the conversion of second to third degree burns by Pseudomonas infections. You're all familiar with the work and the development of many of these agents. First, the silver nitrate, the following year, the sulfonamides by the Brooke Group, and now, through Dr. Fox's work, the combining of the silver ion with the sulfadiazine molecule, and this would seem to be the treatment of choice for the control of superficial infection in burns. Once again, the Brooke Army Group, Curari, Foley, and Pruitt show that even though we are able to control the Pseudomonas infections, we now have to worry about the emergence of opportunistic infections. And their work shows the problem of fungi, viruses that may give us trouble here in the future and may well explain the death of many of our patients where we have controlled the Pseudomonas infection. The third important part of work in burns, I think, has been the ready availability of the xenographic or pigskin homographs for burn cases. Any of you have had the experience of having to go down to the morgue in the middle of the night to try and get skin off a cadaver will appreciate what a great blessing it is to have these commercially available pigskin homographs or xenografts, which can be used not as grafts, but as biologic dressings, which one applies, takes them off every few days, keeps changing them, and this, it appears, does simplify the care of many of our burns. The fourth area in burns that I think is tremendously important and is going to bear a great deal of new study is the work of Monifaux. As you know, he was with Dr. Moyer and did the work originally on the Ringer's lactate as well as the silver nitrate. And now they are developing the use of 3% sodium chloride. This has obviously many inherent advantages. It avoids the giving 10, 15 liters of fluid that has sometimes been necessary in huge burns in big patients, and then the resulting massive edema that has developed, and then having to do the escherotomies and the rest in order to preserve circulation in the peripheral extremities. Certainly, if one can do this with a much smaller volume, supplying the sodium ion that is evidently the important factor in our burn wounds, this may be a whole new step forward in the care of burns.
The next speaker, Dr. James Thompson, is the University of Texas at Galveston as professor and chairman, and he will give us the overview in the gastrointestinal biliary area.
I think we might first say a few words about the state of the art. One of the most important events to occur this year was a Nobel Symposium on gastrointestinal hormones, which showed how far we have come in understanding the mechanism for synthesis, release, transport, storage, action, and destruction of gut hormones, particularly gastrin, pancreazymin, cholecystokinin, and secretin. Dr. Mort Grossman proposed a unified theory of action in which he hypothesized that gastrin and pancreazymin act on one receptor site and secretin and glucagon act on another, and that the two sites interact. The concept of two gastrins of different molecular size was introduced by Yalow and Burson, who earlier in the year had entered the radioimmunoassay fray with a new and exquisitely sensitive method. The entire problem of the formation of gallstones has been reopened by Donald Small and his group in Boston, and I would predict that in the next few years we'll have large sections of the forum devoted to ramifications of this pioneering work. Follow-up studies on Dudrick's important contributions in intravenous hyperalimentation have led the way for the development of home care techniques whereby a patient who do not have sufficient small bowel absorptive surface will be indefinitely maintained on intravenous hyperalimentation. And lastly, I think all of us have been impressed with Dr. Starzl's beautiful studies on the long-term survival of many patients with liver transplants. And it would seem that transplantation of the liver is approximately in the same ballpark that kidney transplantation is, and that we will see now larger and larger numbers of patients with fatal liver disease subjected to transplantation. 3 studies dealt with variations on the stress ulcer problem. Odds, Demir, and Zimmerman found that cortisone actually protected against restraint ulcers, while ACTH made them worse. No conclusive changes were noted in 14 biochemical and hematologic factors in patients with combat wounds that were studied by Strempel, Malott, and McNamara in Vietnam. They were looking for prognostic signs for stress ulceration. Lucas, Sugawa, and Walt studied 25 patients who were prime candidates for stress ulcer and found 13 who bled, 6 persistently. Examination with the gastro camera showed mucosal changes in all 25 patients. Milder changes were limited to the proximal stomach, but in patients with severe changes, the entire fundic mucosa was involved. Only 1 patient had an ulceration of the antrum. Patients who bled had a higher gastric acid level than those who did not. As far as I know, this is the first study, prospective study particularly, that has made that observation. Normal mucin staining of mucosa adjacent to areas of ulceration suggested that there was no diffuse breakdown of the mucin barrier, which again may be another blow amidships to the mucin theory. Two papers dealt with liver-kidney interrelations and the hepatorenal syndrome. Sugarman, Berkowitz, Davidson, and Miller at the University of Pennsylvania gave aramine to patients with the hepatorenal syndrome and noted significant improvement with return to normal renal function. The mechanism of this improvement is only speculative. Handback at the University of South Carolina found that minimal hepatic venous outflow obstruction caused a 39% decrease in renal blood flow and a 59% increase in renal vascular resistance. These changes returned to normal in about 15 minutes after removal of the outflow block. These events suggest the release of a humoral agent. There were 5 studies on jejunal ileal shunts. Thompson and Meyerowitz found fatty infiltration of the liver preoperatively in 24 of 25 patients studied. These were massively obese patients subjected to shunting. Of 12 patients with repeat liver biopsies 15 to 18 months post-op, 7 showed improvement and 4 showed deterioration of hepatic function and architecture. McClelland, DeShazo, and colleagues from Dallas reported that supplemental jejunostomy feedings may prevent liver injury after jejunal bypass by providing extra calories. Sandstead, Brill, and co-workers from Vanderbilt studied the effect of jejunal shunt on body composition. Weight loss after shunt is primarily due to loss of fat, but there is an important loss of lean body mass as well. Occasionally, there is a serious loss of potassium, which emphasizes the need for close care in these somewhat brittle patients. Lickley, Dupre, Chisholm, and Wexler reported on the effect of portocable shunting on the mechanisms that are responsible for the enhanced disposal of glucose given by mouth as opposed to glucose given parenterally. Shunting caused an impaired tolerance to oral glucose that was not accounted for by changes in insulin, and they suggest that the phenomenon of increased tolerance to oral glucose may depend upon gut hormones, which increase the rate of glucose disposal by the liver. Again, this is another emphasis on the endocrine role of the small bowel. Brown and Thompson and colleague from McGill reported that the administration of an elemental diet diminished the formation of pancreatic trypsin. They suggest that this may be caused by a feedback mechanism dependent upon the intraduodenal level of free trypsin. They suggest the use of an elemental diet for patients with pancreatitis.
Now we come to the chairman of the Department of Orthopedics at the University of Pittsburgh, Dr. Ferguson.
There were a number of areas that could be called new in orthopedic surgery presented at this meeting, and I've selected particularly pointing out possible avenues toward improved patient care. The first was in the exhibit area. At Brooke and Valley Forge Army hospitals, they've had an extensive experience in walking femoral fractures, in some instances as soon as 4 days after the fracture. 2 different modes have been used to accomplish the same end result. In this combined exhibit, at Brooke, the principles of containment of the thigh that are embodied in a quadrilateral socket for the amputee are used in making a straight leg walking cast. A knee hinge is added later as callus forms. At Valley Forge, a mini spica is applied hanging from the pelvis, well molded on the thigh, and the knee hinge applied after 6 weeks in traction. The ankle and foot are free in this mini spica, and walking pushes the limb up through the cast. The improved physiology of the soft tissues is reflected in a healing time of 5.5 months and a return to duty time of 7.7 months. Angulation has been controlled and non-union is virtually non-existent. The mini spica technique appears easier for the non-initiated, and for fractures below the mid-shaft area of the femur, there is a happier patient and an improved end result. Happily, this technique may spell the death knell of open surgery for supracondylar fractures of the femur, because really the more comminuted the fracture, the more indicated this type of therapy is. The research area a technique for the assay of osteolytic activity of bone opens up a new area of evaluation of therapy affecting this activity and could greatly increase the knowledge of what is going on in conditions such as Paget's disease. A collagen substrate in the form of a gel is made from the skin of the rat. It is pre-labeled with glycine carbon-14. Bone cells obtained by biopsy are introduced on this gel, and the liberation of radioactivity counted in the supernatant after 90 minutes. Normals were remarkably constant, and the increase in conditions such as Paget's disease was obtained. And interestingly enough, this was obtained even when the histology of the biopsy was normal, pointing out perhaps that Paget's is a general disease and opening up great avenues in understanding. If this technique stands up, much of the mystery of therapy for conditions such as osteoporosis may be cleared up. And no summary of what's new in orthopedic surgery could be complete without mentioning total hip joint replacement. The initial success of this procedure tends to lead to its overextension. The fact that there are many unsolved material and technique problems tends to be overlooked. Similar enthusiasm was rampant after the introduction of the acrylic prosthesis years ago, which ground away digested by human tissue fluids after 2 years. Total hip replacement was neatly done. The signs pointing to caution are present even earlier with this procedure than with other early successes. The patient walks early, without pain, and discards walking aids quickly. The patient is usually eminently satisfied with his early result. In the background are signs pointing to difficulty, and a few are these. Cardiac arrest has occurred on introduction of the plastic molding compound in which the hip components are seated. It's not a glue. It merely accurately mirrors the irregularity of the seating receptacle in the patient. 2, a peculiar induration of the wound has been found to persist for many, many months. 3, a climbing late infection rate has occurred over the first 2 years in series that have been followed that long. 4, a metal-to-metal surface friction and wear problem that has not been solved in any previous implant where 2 metal surfaces have had to work against each other is present in this particular device. And 5, there has been a plastic implant used to solve the metal-to-metal problem in some types of total hip joint replacement prostheses, and it appears to do so until one recalls the inability of virtually any plastic implant device to remain unchanged in a human tissue environment. At the moment, until more facts are in, this apparatus and operation should be limited to those with limited life expectancy or a situation so desperate that there is no other feasible solution.
The next specialty session is that of urology, but Dr. Keith Waterhouse, who's professor and chairman of the downstate New York Department of Urology.
First paper that I want to discuss with you is that of Dr. Ronald Katz from the College of Physicians and Surgeons in New York, talking about anesthesia in adrenal surgery and discussing in particular anesthesia for patients with pheochromocytoma. Dr. Katz told us that in his hands the use of preoperative preparation of the patient with alpha and beta blockading agents such as dibenzamine and propalanol has now been abandoned, and that he prefers to control the blood pressure with intravenous sodium nitroprusside. He uses 500 micrograms in 500 milliliters of Ringer, and the blood pressure is monitored throughout the course of the procedure by an intra-arterial catheter and not by a blood pressure cuff. He pointed out that the cardiac arrhythmias, of which we are all so fearful, are associated with a raised blood pressure, and that control of the blood pressure controls the arrhythmias. It is his practice to allow the blood pressure to rise in the early phase of the procedure to determine the critical pressure at which arrhythmias occur as monitored by electrocardiography, and then control the pressure with intravenous sodium nitroprusside to a level safely below this critical point. The use of sodium nitroprusside as against alpha and beta blockading agents has the following advantages. One has minute-to-minute control of the blood pressure with the ability to get the patient back into the recovery room off all drugs, and particularly off pressor agents. And one has the option of allowing the surgeon to search for the difficult tumor by palpation and watch for the rise in blood pressure. Dr. Wienemer, one of the surgeons who works with Dr. Katz, described just such a case in which the pheochromocytoma was not in either adrenal gland nor in the organ of Zuckerkandl, but was situated behind the vena cava at the level of the renal veins, and was only discovered by a hypertensive episode induced by careful palpation at the time of surgery. This tumor could probably not have been discovered if alpha blockade had been used preoperatively. In the last 15 patients in whom Dr. Katz has given the anesthesia using this sodium nitroprusside technique, no pressor agents have been used. Dr. Katz also reiterated the point known to many of us, that patients with pheochromocytoma are chronically vasoconstricted and have diminished blood volumes. In their patients, the average being a diminution of 12%, and that in order to achieve hemodynamic stability, whole blood replacement of this volume, plus the volume of blood loss, is required after the removal of the tumor. Turning now to another topic, that of carcinoma of the prostate, we're all aware that in 1967, a cooperative study by the Veterans Administration Urological Group showed that in patients being treated with stilbestrol for stage C and D carcinoma, there was a marked increase in cardiovascular complications leading to a substantial mortality. Prout and his group at the Medical College of Virginia therefore studied the problem of whether small doses of stilbestrol can lower plasma testosterone. They showed that doses of as little as 1 milligram of stilbestrol daily will lower plasma testosterone to levels as low as much larger doses and to levels approaching that seen in the castrate. It would seem that all of us should go to these much lower doses in our clinical practice, and there's a preliminary report not presented at this Congress, and again from the Veterans Administration Cooperative Group, that the clinical results in patients with grade C and stage D carcinoma of the prostate treated with 1 milligram daily of stilbestrol are equally good as with larger doses, and that the incidence of cerebrovascular complications is substantially reduced.
And now the final session will be on transplantation. Dr. John Manick, of course, is widely known for his work in this field and will give us what's new in the field of transplantation. John.
I must admit that there are a few problems that remain to be solved in this field, even at the conclusion of this session of the college. I think, in fact, that there is a considerable pall of gloom over the field of clinical organ transplantation by the increasing body of evidence that suggests that tissue typing is really not working very well. In fact, it seems rather clear that the matching of the donor and recipient of an organ graft by the typing of their lymphocytes with available panels of antisera does not predict what is going to happen to the kidney graft or organ graft survival, except in the case of transplants between siblings. Dr. Paul Terasaki, for example, who has probably got the world's greatest experience with tissue typing with antisera, reports that his matching grades of A, B, C, and D with regard to kidney transplant donors and recipients has had no predictive value in transplant survival except in the case of sibling transplants. Now, as you might imagine, there has been considerable scurrying to attempt to salvage something out of this multi-million-dollar enterprise throughout the world, and indeed there are some rays of sunshine in the generally gray atmosphere. For example, Drs. Coons and Belzer at the University of California have been typing their transplant owners in cadaver donors. At any rate, they've been transplanting the transplant donor's kidney cells rather than his lymphocytes with their antisera, and they have been picking up antigens on the kidney cells that they can't detect on the lymphocytes. And using this technique, they have found that pre-transplant typing has been helpful. The amount of mismatching, or the transplant grade, as indicated by the A, B, C, and D, in their cadaver kidney donors has been quite effective in predicting what happens. For example, the B-matched cadavers are all doing well, the C-matched cadavers are not doing so well, the D-matched cadavers are doing rather poorly in their experience. There are others who have similar results, which suggests that typing is not totally fruitless, though it is probably not working in its present form. For example, Dr. Felix Rappaport, in using Professor Dosay's methods of calculating the prediction of undetected antigens on lymphocytes, and also Professor Dosay's recent work in attempting to define cross-reacting antigens on human lymphocytes, when one applies these calculations to the typing results, one comes out with a much better looking match between the typing and what happens to cadaver kidney transplants, at least in Europe. Certainly this gives us some hope for the future. In addition, Dr. Terasaki, who of course is not about to go out of business in spite of his recent bombshell with regard to the failure of his current methods to predict transplant survival, feels that computer analysis of his data now permits him to predict whether or not a given mismatch is important depending upon the antigenic makeup of the recipient. In other words, mismatching for one antigen is more important if you have antigen A, for example, than if you have antigen B. And he feels that this kind of prediction will be of real value in determining what will happen to a cadaver kidney transplant. Finally, Dr. Fritz Bach has presented evidence that another typing technique, the mixed lymphocyte culture technique, which has been recently refined in his laboratory, may have some real predictive value with regard to the degree of incompatibility between donors and recipients of cadaver kidney transplants. And there is a sort of normal distribution curve of the degree of stimulation in this test in the population at large. And he feels now that this degree of stimulation is correlated with the number of important antigenic mismatches between donors and recipients unrelated of organ transplants. I think that there is, on the bright side, real evidence now that preservation techniques by cooling an organ graft, particularly a kidney graft, and perfusing it with a cold solution that resembles in composition intracellular fluid is a perfectly satisfactory way of preserving a graft for 12 to 24 hours, and this permits time to transport this graft all over the country, in fact probably all over the world with jet aircraft, and give this kidney to an appropriate recipient. Some data collected by Dr. Stevens at the University of Utah and head of the North American Network for Kidney Sharing shows that kidneys that have been transported, these are cadaver kidneys, of course, they've been transported to their recipients, function just as well as far as their percent survival as those that have been transplanted within the same institution. And some of these kidneys have been flown clear across the United States, at least 3,000 miles away, and then put in. As far as liver transplantation is concerned, it is by no means an office procedure as of this date, and the experience of the group with the largest experience in this field was summarized by Dr. Tom Starzl at this meeting. He finds that he currently has a 27% one-year liver transplant survival. His longest survivor is slightly over 2 years. There are no really long-term liver transplant survivals as yet. He's also found that the use of transplantation for hepatoma, or primary liver cancer, is probably not going to be very feasible, since recurrence of the cancer in these patients has been almost universal. Certain basic problems in transplant rejection have been studied by speakers at this session. For example, Coons, Belzer, and Cockrum at the University of California have studied their human transplant recipients by in vitro techniques to determine what the kind of antibody or immune response is in their patients who are rejecting their kidneys, and they have found, and I think this has become increasingly apparent, that both humoral and cellular immunity is involved in organ transplant rejection. In fact, one of the most interesting features of their study was the demonstration that there is a synergism between circulating antibodies and immune lymphocytes in transplant rejection, which can be demonstrated by tissue culture technique, and that neither the antibodies nor the immune cells are effective alone, whereas both together destroy the donor tissue. Dr. Warren, I think that's what's new in transplantation.
And with that presentation, we conclude what's new for 1970. Thank you.
Thank you, gentlemen, and our thanks, too, to the Board of Regents of the American College of Surgeons for cooperation in recording and disseminating this material. Coming up, one of the most clinically valuable sessions at this year's ACS Congress, special problems in gastrointestinal cancer, with Robert M. Zollinger, Claude E. Welch, H. William Clatworthy Jr., Harry S. Goldsmith, William P. Longmire, Anthony R. Carrere, and J. Engelbert Dunphy. Audio Digest Surgery is produced and copyrighted twice each month by the Audio Digest Foundation, a non-profit subsidiary of the California Medical Association.